Hi, my name is Jordan, and today I'm going to be giving a presentation on gastroesophageal reflux disease, otherwise known as GERD. And I've provided a case scenario here of maybe what a potential patient could look like. So, a 45-year-old male presents to the primary care office with a 3-month-old history of intermittent burning chest discomfort, primarily occurring after meals and worsening when lying down. He reports a sour taste in his mouth, especially in the mornings. His symptoms are aggravated by spicy and fatty foods, but are not associated with shortness of breath, nausea, or weight loss. His medical history includes hypertension, seasonal allergies, and he takes lisinopril daily and loratadine as needed. He has a 20-year history of smoking, drinks coffee daily, consumes alcohol occasionally, has a family history, is significant for father's history of peptic ulcer disease, and on exam he is well nourished, and has a BMI of 29 and vitals within normal limits. His oropharynx is clear, lungs are clear, his cardiovascular exam is unremarkable, his abdomen is soft, non-tender, and non-distended with normal bowel sounds. He reports occasional bloating and belching, but denies any difficulty swallowing, any GI bleeds, or significant weight changes. So, a little bit about the pathophysiology of GERD. This is not straightforward, to say the least, just because GERD has a wide variety of possibilities that could be causing it. But gastroesophageal reflux disease simply just refers to symptoms or complications that relate to the retrograde flow of gastric contents back into the esophagus. And obviously, in healthy patients, the anti-reflux barrier works to prevent that reflux into the esophagus. And that is simply just a barrier comprised of the lower esophageal sphincter, the extrinsic crural diaphragm, and other structures of the GI flap valve. And when these protective components don't work appropriately, patients are then at risk for reflux exposure. But also, patients who have poor epithelial resistance or they have increased visceral sensitivity may have a normal reflux burden, but also present with symptoms. So GERD may also be caused by a hiatal hernia, which can change the position of the acid pocket, which promotes reflux. And the acid pocket is just a layer of gastric juice that is directly above the food bolus and below the esophagastric junction. So this is all just to point out that the point of treating someone with GERD is to treat the underlying cause, of which there can be many. And there are risk factors associated with GERD. Obesity is a large one. Pregnancy, people who smoke tobacco or drink alcohol excessively, but also people who have motor abnormalities like transient LES, and that's that lower esophageal sphincter relaxation, or who have delayed gastric emptying. And that can also be caused by certain medications. For example, Ozempic, it works by causing delayed gastric emptying, and so that can maybe cause some problems as well. Typical clinical presentation, these are like the most normal symptoms that you could see. Patients who have heartburn, regurgitation, dysphagia, belching, epigastric pain, nausea, and even like that sour smelling breath. Screening for GERD is not recommended. However, diagnosing GERD is quite complex because, as we talked about, there's really not one causative agent for GERD, and so there's no gold standard for diagnosing it. But one of the most important factors is the patient presentation and their history. And an upper endoscopy can be used to assess for like irritation and inflammation in the upper GI tract. But this can help to determine the presence of a hiatal hernia as well, which, as we talked about, can also cause a lot of GERD symptoms. pH testing can be done via impedance, I think is how you say it, testing, or Bravo testing, which just assesses the pH or acidity level within the esophagus. And I just want to point out the first one, impedance testing, that's more like a catheter that remains it goes through the nose, down the esophagus, and it's kind of like wrapped around the ear for about 24 hours, whereas the Bravo is like a little capsule that's placed and then removed maybe 2 to 3 days later. And they both do the same thing by like assessing the pH level and assessing like how much gastric contents are regurgitated, if any at all. And then if a hiatal hernia is suspected, or if the patient presents with difficulty swallowing, a barium swallow test may be done, but this isn't necessarily considered like a great diagnostic test for GERD itself. So, pharmacological treatment and management. Obviously, we moved pharmacological treatments after non-pharmacological treatments have been successful, but this is also based on severity of symptoms that your patient is presenting with. We may have to skip that altogether if we're presenting with some really concerning symptoms, or if this is like really altering their ability to live their life in a normal way. So there are two main primary pharmacological agents, and that is histamine receptor agonist and proton pump inhibitors. So PPIs are considered to be the most effective, and that is for both erosive and non-erosive GERD, and they basically work to inhibit acid secretion. And that is simply because contact with acid to the esophagus is what leads to symptom production and causes inflammatory lesions, and so preventing that is a large focus of treating GERD. They're very effective in healing esophageal mucosal alterations, and some common PPIs are omeprazole, pantoprazole, esomeprazole, and then some common histamine receptor agonists you may have heard of are famotidine and cimetidine. Some physicians may also prescribe potassium competitive acid blockers. These are just anti-secretory drugs. Their onset of action is immediate, and gastric acid secretions can be controlled after just the first dose. And this drug also does cover daytime and nighttime symptoms. So then in some cases, patients could be moved more towards surgical treatment. And these procedures could be the laparoscopic Nissen fundoplication, the laparoscopic anterior fundoplication, or bariatric surgery. So the laparoscopic surgery is a procedure that reinforces that valve between the stomach and the esophagus. And this procedure can also be used to treat hiatal hernias, which, as we discussed again, is a big causative factor for GERD symptoms. And there are various types of bariatric surgeries that may be utilized to support weight loss in patients. And this is just important because, as we discussed, symptom onset and the severity of these symptoms is worsened and brought on by obesity. So patient education is kind of all over the map, but patients need to understand the importance of weight loss, and they need to understand that obesity is a major risk factor to developing GERD and for worsening symptoms. And so we need to educate our patients on diet and exercise. They need to avoid risk factors like smoking and excessive alcohol consumption. They also need to be informed to stop eating 3 hours before bedtime and not to lay down and take a nap 2 to 3 hours after they eat. And even just management techniques such as elevating your head while you're sleeping, that can help patients, and avoiding eating larger meals. So follow-up, this is kind of complex. GERD is something that you're going to treat with your primary care provider. It's not something that you're going to treat in the ER. These people need to be following up with their primary care provider, talking with them, having ongoing conversations, mostly in the beginning stages to pinpoint specific causative agents for GERDs, because as we discussed, it is multifactorial and it can be prompted by many different factors. So we need to pinpoint what is causing it so that we can treat the primary cause. And there needs to be ongoing conversations regarding the success of non-pharmacological management. You know, we're treating with diet and exercise. Did that help? Was that successful? Are your symptoms better? Are they worse? And then together we discuss and we go to the next stage, which is pharmacological management. And the patient and the provider will need to be in communication regarding the success of these prescriptions. After prescribing a pharmacological treatment for GERD, the patient should follow up in about a month. And this is just to see, again, did our symptoms improve? Did they get worse? Do we need to change something? Do we need to change to a different medication? Do we need to change our dosage? And things like that. And then maybe we become more concerned and we realize, this may require a referral. Patients who have very severe symptoms and have multifactorial stuff going on, like GI bleeds or tarry stools or trouble swallowing, things like that, or they have persistent symptoms that despite lifestyle modifications like diet and exercise and pharmacological treatments, their symptoms are getting worse or they are the same. These people should be referred to a gastroenterologist. And the role of the APRN is quite simple. One is advanced clinical assessment. As we discussed, GERD, it is so important to really listen to your patient. The history and physical and patient presentation is the most important factor in diagnosing GERD. So we have to be listening very intentionally to what they are telling us. And then we have to work diligently to decide what is causing this. Is it a hiatal hernia? Are there motor abnormalities in the lower esophageal sphincter? There are certain tests that we need to be doing to assess these factors so that we can better treat this patient. We don't just want to throw a Band-Aid on it. And 2 is patient education and lifestyle modification counseling. We need to really be doing a good job of providing clarity to these patients about how they can improve their own health and what role they can play in that. And the next is evidence-based pharmacological management. Research is changing all the time. Things are recalled. There are new treatments that come on the map. And so it is very important that we stay on top of evidence-based research and that we are providing the best recommendations for our patients when it comes to pharmacological management, and that we're not doing this too early or we're not doing it too late. And the last is interdisciplinary collaboration and appropriate and timely referrals. We need to be on our toes about assessing for serious symptoms that these patients are having, or noticing that we have done a pretty thorough treatment regimen and there is no improvement, or these symptoms are worsening, and to have the humility and the wisdom to be like, yes, we need to refer this patient to a gastroenterologist. And lastly is the Christian worldview, and this is another role of the APRN or the DNP, and that's just to walk alongside these patients, and that is by providing support, clarity, therapeutic listening. These patients are experiencing some symptoms that really affect their day-to-day life, and that is so upsetting. And a lot of times these people just want to be heard. They just want someone to listen to them and to be validated that, yeah, they're dealing with something that is difficult. And that is something that we can provide. But it can be difficult because providers can become desensitized to the patient's experience, because we see it day in and day out with all these types of different things, and we just get a little numb to it. And this is where continual communication with the Lord is so vital, not only to my own heart posture, but also to the patient's experience. And so this requires us to just be constantly in prayer and constantly asking the Lord to renew our minds and to keep our hearts soft to people and to their experience and to what they're feeling. And for this, in my own life, I look to Ephesians 5:16, and it just says, make the most of every opportunity in these evil days. Don't act thoughtlessly, but understand what the Lord wants you to do. And this section is just talking about living by the Spirit's power. This may seem like a smaller application of this verse, and I do think this verse is more in line talking about with living according to Scripture and not being a friend to the world and succumbing to that. But I also think it can just be very helpful in remembering to be very intentional about every patient interaction that we have and to pursue it in a way that is honoring to the Lord. And I won't read the next one because it's long, but I also refer to James 5, 13 through 18. And this section is just talking about the power of prayer, and it's just a really good reminder that we have access to Him 24/7 to discuss with Him and to thank Him and to ask and pray bold prayers. Lord, let my heart be soft. Do not let my heart be hardened. Renew my mind. Give me wisdom. Help me provide the best care possible in a way that's honoring to you. And that's really all we can do. So thank you guys so much.